Welcome to today's webinar, Recognizing and Treating Prehospital Shock. We are excited to welcome our presenters, Dr. Ray Fowler and Dr. Melanie Lippmann. NAMT would like to recognize our sponsor for today's webinar. On behalf of NAMT, we extend a warm thank you to Ninth Brain. We thank Ninth Brain for their continued support in advancing the EMS profession and caring for our nation's EMTs and paramedics. NAMT's pleasure to introduce today's presenters, Dr. Ray Fowler and Dr. Melanie Lippmann. Dr. Raymond Fowler, MD, FACEP, FAEMS, has been an EMS physician and a leading educator, medical supervisor, and political advocate for more than 4 decades. He is the James N. Atkins, MD, Distinguished Professor of Emergency Medical Services, and the Chief of the Division of EMS, Department of Emergency Medicine, University of Texas Southwestern Medical Center. He was a co-founder and the second elected president of the National Association of EMS Physicians. In addition to his many other accomplishments, he was a co-founder and senior faculty member of the National EMS Medical Director course. Our other presenter is Dr. Melanie Lippmann, MD, FACEP. Dr. Lippmann is an associate professor of emergency medicine at Brown University's Alpert Medical School. Since completing her emergency medicine residency at Yale, she has sustained a particular interest in caring for patients with psychiatric emergencies and substance use disorders in the emergency department and the pre-hospital setting. She also has a long-standing interest in teaching and mentoring students. Welcome, Dr. Fowler and Dr. Lippmann. I now turn the presentation over to you, Dr. Fowler.
Thank you.
Thank you so much. It's an absolute pleasure to be with you. This afternoon, at this very strange time in the history of medicine, the worst pandemic in a century, we have a monster hurricane approaching my state, the Gulf Coast of Texas and Louisiana. It's a useful time for us to kind of take a step back and think about the approach to the patient in the pre-hospital arena, about how we examine patients and we draw conclusions. Ladies and gentlemen, I want to make a few points, Melanie and I do, that are very straightforward. There are some parts of the evaluation of the patient that are really quite simple, but you have to look. And that's the point we're going to make today. Melanie, why don't we do a case?
Sure.
Your patient is a 64-year-old woman who presents with generalized weakness and lethargy. Your assessment reveals she's tachypnic, rapid breathing, and tachycardic, and her skin is cold. Her past medical history is significant for frequent urinary tract infections, hypothyroidism, type 2 diabetes, and hospitalization for pneumonia 6 months ago. You already know there are multiple issues of a past medical history going on. She recently finished a trial of an antibiotic for an upper respiratory tract infection. She was exposed to a medication. Her blood pressure is 76/54 millimeters of mercury. She is in shock. Her pulse rate is 114. That is abnormal. Her respirations are 24. That's too high. And her oxygen saturation is 96%. So what's your initial impression? Sick or not sick? I know that's simple, but is she sick or not sick? Melanie, is this a sick person or not?
Sick. Yeah, I'm pretty worried. Worried.
Already. So already, what differential diagnoses are you considering based on the information you have now? Well, go ahead, Melanie.
Yeah, I mean, it sounds like she's in shock. You know, I think we might take this moment just to talk about the shock index, which is briefly her heart rate over her systolic blood pressure. Typically, if you think of a heart rate of like 60 and a systolic blood pressure of 120 in a normal person, you get a ratio of 0.5. Anything between 0.5 and 0.7 is normal, but when you get above 1, be very worried. I mean, you don't even really need to do the division, but if you see a patient where the heart rate is greater than systolic blood pressure, be very concerned. Like this woman has a heart rate in the 1-teens, she's 114 with a systolic blood pressure of 76. That's 1.5. Like she's definitely sick. This is shock for sure. In her, I would be most concerned for sepsis. It sounds like she's a diabetic. She's had UTIs before. She's had pneumonias before. Maybe she failed a course of an antibiotic. Maybe she's been recently hospitalized for her pneumonia. I think septic shock is top of my list. But just keep in mind, when this shock index is markedly elevated as it is, in sepsis, that predicts need for lots of fluids and maybe vasopressors. And it also predicts a 28-day mortality rate that's markedly increased. If she were to have a markedly elevated shock index in the setting of hemorrhagic shock, like blood loss, it markedly predicts a need to receive blood. So be worried. I'm pretty worried about her.
So wait a minute, Melanie. You want our medics that are listening today to learn a new equation? Are you kidding me? Wait a minute.
It's not even, it's not, there's no math involved. It's the heart rate versus systolic blood pressure. If heart rate's greater than systolic blood pressure, I'm worried.
All right, well, wait a minute. So I'm sitting here and my pulse rate, I hope, is around 60. And I hope my systolic is around 120, unless this hurricane's got me hypertensive. But say 60 divided by 120 is 0.5.
0.5.
So the equation you want our medics that are listening to learn is that you want to take pulse rate, in this case 60, and divide it by the systolic, and that's 120. So that gives you a dividend. That gives you a result of 0.5.
Right.
So when does it get abnormal?
Well, as we said, 0.5 to 0.7 is normal. Anything above 0.7 is technically abnormal, but I think, like we said, let's make it easy. You don't even have to do the math. Once their heart rate gets above their systolic blood pressure, your ratio is 1 or above, that's when you really need to get worried. Like that's when the mortality rate really goes up. There's no math involved. It's just heart rate greater than systolic blood pressure, sick.
All right, so what you're really telling me, if I put them on a monitor and I find a rapid rate on a monitor, or at the bedside, I put my hand on the radial pulse and they have a weak radial that's very fast, and I get a systolic that's low, I can assume this patient's in trouble.
That's bad. They're probably in shock of some type.
All right. So what additional information will we need to narrow our differential? Well, we look at their history, we do a physical, we'll go through all that. What are the initial treatment priorities as we go forward? We'll go through that. And on the basis of your findings on this patient, what is the, shall we say, refined differential diagnosis and why? Why don't we go through all that? Shock, folks, you've got to understand is something that's happening mostly invisible to you at the bedside, with the exception of skin color, moisture, temperature, capillary refill time, the rate of the pulse, and the level of the blood pressure and the respiratory rate. You could throw into that the patient's mental status as well. But what is happening with this activation of the sympathetic nervous system is that cells are being starved for oxygen and glucose. This is cellular hypoperfusion, in which insufficient oxygen is being available to meet tissue demands. You got to understand that when shock occurs, the body is sick, it's in distress. The shock response is mounted by the body to attempt to maintain systolic pressure and get blood to the brain perfusion during times of physiologic distress, whatever that distress may be, hemorrhage, pulmonary embolism, and so on. This shock response can accompany a broad spectrum of clinical conditions that stress the body. It could be heart attack, major infections, or allergic reactions. Shock is caused when oxygen intake to the cells, absorption, and delivery fails. As you may say, the vascular system has failed. Or when the cells, for some reason, are unable to take up and use delivered oxygen to generate sufficient energy to carry out cellular functions. Things like what? You poison someone with cyanide, one of the worst toxins anywhere, and the cells cannot take up the oxygen. We'll go through all this as we move forward. There are 4 types of shock. 4 types of shock. Low volume, high space, and then some obstruction to flow and a failure of the pump. Let's talk about it. Hypovolemic shock is when there is inadequate circulating fluid in the vascular system, leading to a diminished output from the heart, which results in an inadequate delivery of oxygen to the tissues and the cells. Melanie, you want to cover distributive?
Yeah, I mean, just one piece about hypovolemic shock. I think that something that you might see a lot in a pre-hospital setting is hemorrhage. So if you come upon a trauma patient, they could be losing massive amounts of blood onto the street or into the field, or from a variety of massive GI bleed, trauma, that's a type of hypovolemic shock. And of course, like, just keep in mind, like, they're losing blood. The thing they need back is going to be blood.
So tell us about distributive shock.
Distributive shock. So this is something like sepsis, I think, is a good example. You lose vascular tone I guess kind of what happens is your capillaries become leaky and the vascular resistance becomes compromised, so that essentially, like, blood is you lose the vascular tone of your vessels, so that it's kind of really the way that the blood pressure drops. And these people, in addition to needing volumes, might need something like a vasopressor, which increases that systemic vascular resistance.
So let me see if I understand this. Blood pressure equals cardiac output times peripheral vascular resistance.
Correct.
Cardiac output is how fast the heart beats and how strong. And peripheral vascular resistance are the arterioles way out in the end of the arterial system. So you're saying that in distributive shock, those arterioles open. Is that correct? And allowing the pressure to drop. Yeah. It's a little bit like, Melanie, the way I think about it, it's a little bit like if you know, let's say you wanted to water the flowers in the yard, and it's real hot outside, but unfortunately the flowers are 50 feet away and you got a 25-foot hose and you don't have one of those screw things. So you turn the water on and you put your thumb on it, which raises the pressure in the hose and allows the fluid to come out. So in a way, distributive shock is sort of like taking your thumb off the hose, isn't it?
Yeah, exactly. Or it's like, imagine if you were watering with a hose and all of a sudden the hose became very dilated, the flow would go massively down. So you want to get that flow up, you want to tighten up the hose.
So thus, distributive shock is an increase in vascular capacity. You say, well, that sounds healthy. It isn't. What Melanie just said is that the vessels become too large and cannot maintain blood pressure. As you said, the capillaries also leak, translating into too little vascular resistance. The thumb comes off the hose. You mentioned sepsis. It could also be stung on the butt by a bee, anaphylaxis, causing the arterioles to dilate due to a histamine reaction. We'll come back to that. Let's go to the next one. Cardiogenic shock is where the heart messes up. The heart is unable to circulate blood. The heart becomes weak for some reason and thus cannot meet the metabolic needs of the body. Either right side of the heart, remember there are two sides of the heart, that which receives blood back from the body, the right side, or the left side of the heart, that which pumps blood out through the aorta. Either the right or left side can fail, leading to what's called cardiogenic shock or heart shock. And it can include dysrhythmias, I'll show you one, or arrhythmias, a cardiac structural disorder like a heart attack, we'll talk about that, or perhaps the action of certain toxins that can affect the heart. The COVID virus right now, we know, causes a myocarditis, for example, which damages the strength of the heart. What about obstructive shock, Melanie?
So obstructive shock is maybe something like a big pulmonary embolus, or as you mentioned on the slide here, a tension pneumothorax, like the heart is having to pump against an obstruction like a PE or like a pneumothorax that until you relieve that obstructive process, I think, well, that's the underlying pathology. That's kind of what you're fighting against. And maybe just to go back to the cardiogenic shock, just as you said, the mean arterial pressure is a product of cardiac output times systemic vascular resistance. The distributive shock, what we were doing more with the vasopressors to increase the vascular resistance. In cardiogenic shock, you might need something more, I think we'll get to in the future, like in inotrope, which actually increases the strength of the cardiac contraction, something like dobutamine.
So you mean like in a massive heart attack? If the blood, so you tell me blood pressure equals cardiac output times peripheral vascular resistance. And cardiac output is made up of the strength of the heart and the rate of the heart. So you're saying that if there's a heart attack and the heart muscle gets weak, the strength of the heart goes down and thus blood pressure goes down. So you're
Right.
saying there are chemicals available that can make the heart beat stronger?
Yeah, so sometimes it's not just that you need to increase the resistance in the vessels, but when the heart is the problem, like the pump is actually failing, it can't pump hard enough. You might need something called an inotrope. Like, for example, dobutamine actually increases the contractility of the heart, helps it pump stronger.
So going back to obstructive shock, so Melanie, you're telling me that you can get like a pulmonary embolism, a blood clot to the lung that's so big that it can actually block the blood flow coming out of the right ventricle?
Yeah, I mean, the ventricle is trying to pump against a pressure that it cannot overcome.
And also, well, why does fluid around the heart in the pericardium, why does that cause a problem? Does it keep the heart from filling?
Well, that's the problem is that, you know, if you imagine the heart is contained within the pericardium, which is a relatively like inflexible sac. Once that sac, the heart is in a sac that doesn't really have much room to expand, right? Like once there's blood or fluid of some sort on the outside in that pericardium, the pressure of the pericardial fluid is going to be greater than the pressure that the heart can generate to pump. And that's how
so if somebody takes an ice pick to the heart into the right ventricle, which is now bleeding into the pericardial sac between the pericardium and the heart, it can actually fill up that pericardial sac. Is that right?
Sure. And once the pressure becomes so great in that sac, the heart just cannot overcome it.
And so the heart really can't fill because there's so much blood around it, it's keeping it from filling. That's a pericardial tamponade. Or in the setting of a tension pneumo, when the lung develops a pneumothorax, but then when the patient breathes, diaphragm goes down, the intercostal muscles go out. That pulls air out into the pleural space, ultimately causing a large positive pressure in the pleural space, which unfortunately prevents the heart from filling. And if the heart can't fill, then it can't pump. Is that right?
Yes.
Okay, so let's move on. So, folks, there are signs and symptoms of shock, and the definition of a great medic, and folks, you want to be a great medic. We say in emergency medicine that the difference between a specialist in emergency medicine and a generalist, an average doc, is in the rigor of the application of a differential diagnosis. What in the world does that mean? It means that we try to figure out all the things that can be going on. Folks, this absolutely applies to EMS. I've had an almost 50-year career in EMS, and you want to be a great medic. What's a great medic? Appreciate signs and symptoms at the bedside, can do a good history, conduct a brisk, thorough, accurate physical exam. This is not kidding. This is where EMS is today, ladies and gentlemen. There's no better example of that than shock. Shock is something that can be quite subtle. It can be a cool skin, delayed capillary refill, a pale patient, someone with a little bit of air hunger. It can be quite subtle. Let me give you an example. The systolic blood pressure disappears after, start over. The radial pulse disappears after the blood pressure falls below about 80. The femoral pulse disappears below about 70. The carotid pulse disappears below about 60. So you can come to the patient who is air hungry and wet and cold, and you feel their radial. And if you can feel their radial, what statement can you make? Well, at least their systolic is 80. But what if you can't feel a radial, but you can feel a carotid? You can say immediately, just like that, that their pressure is between 60 and 80. This is true. This defines a great clinician, ladies and gentlemen. And that's what you want to be. Let's look at this shock. Let's look at the slide on shock. Shock occurs in about 3 phases. Compensation, when the vascular system is trying to hold on and maintain perfusion to the brain. The brain are where the receptors are that stimulate the sympathetic nervous system, which is what constricts the arterioles and makes the heart beat stronger and faster. At some point, compensation fails. in which we call then decompensation. If you look at hemorrhagic shock alone, you can generally state the following. Listen to me. The order of the onset of the signs of hemorrhagic shock are in the following order: weak, thirsty, lightheaded, then pale, then diaphoretic, then tachycardic, then tachypnic, and then the last sign of increasing compensation before decompensation occurs, which is diminished urinary output. Ladies and gentlemen, you carry plenty of people who have Foley catheters in them. Normal urinary output is about 1 cc per minute. And if you're with a patient for an hour, which is a typical run from start to finish, they should be putting out 50 to 100 cc's per urine. And if they don't, they're in shock. You have to be careful. And then compensation fails. It's called decompensation. And that is weak pulses, altered mental status, coma, then cardiac arrest, and death. So let's summarize. Compensated shock, look over to signs and symptoms in the yellow box. They get cool, they get pale, they get restless, they get anxious. Urinary output can go down, as I mentioned. And then decompensation fails. Ladies and gentlemen, you need to have a blood pressure of 120/80. If it's some old guy like me, the pressure may be higher. But if you got a pressure under 120/80, you have to consider that decompensation has happened. What does that mean? It means that the vascular system has failed to maintain perfusion. This patient is about to die. We get very complacent about patients. Oh, well, his pressure is about 90. And we get complacent with that. Folks, with hypotension, the vascular system has failed. The patient is about to die. The decompensated patient typically is quite mottled. They could be cyanotic, depending on the condition. Cyanotic would occur in the setting of tension in the thorax, cardiac tamponade. They obviously are very weak. They would have a metabolic acidosis, which we'll talk about momentarily, quite anxious if they're awake, and absent or diminished radial pulses. And finally, there's a thing we'll talk about in a second, which is irreversible shock, where the cells are so starved for oxygen that were we to test for the lactate level, which we'll come to, is that the lactate levels will be elevated, meaning that anoxic or severe hypoxic circulation is occurring. So what do? You go to the scene safety. Look at the patient initially. You do a primary survey. We'll come back to all these. And then you sort of take your first impressions. Talk to the patient. At some point, a secondary survey, when you've done the initial resuscitative maneuvers, that's a head-to-toe, vertex to toenails exam of the patient. We put on our diagnostics, pulse ox, capno, ECG, some laboratory studies we may do in the field. We then compute the differential diagnosis. We'll come to that. And then ongoing management, fluid, temperature regulation, vasopressors, and administration of blood products. We'll talk about all these. You walk up to the scene. Folks, it is not your job to get hurt. It is not your job. If it's a dangerous scene, don't go in there. It is not your job. It's critical in approaching any patient. And when dealing with a patient who is critically ill, it's easy to miss a safety issue. So take the time so you don't get hurt. Now, for the patient that you think may be in shock, altered mental status, tachycardia, cold skin, diaphoresis, weak pulses, rapid pulses. Do you see signs of a life threat? Principally, do you see spurting arterial bleeding? As you approach the patient, you've got to stop bleeding. You have 5 liters of blood in your vascular space, which is about 10 units of blood. And if you have a patient who has spurting arterial bleeding, they can quickly bleed units of blood very quickly and have a lethal injury. Does the patient have altered LOC or respiratory distress? Is the skin cold? Is the skin wet, pale, ashen, diaphoresis, mottled? Do you see hives, for example, like you might see in anaphylaxis? Do the surroundings suggest the possibility of shock for us, such as vomit? I would add to that diarrhea, such as blood. You say diarrhea, gross. Cholera kills through awful diarrhea. That's where they lose their vascular volume. You want to do your physical assessment. You want to take a history that helps you identify and treat the threats to life to complete these interventions. Generally, speaking to the patient as you're talking to them, really look from the top down, sort of a 1, 2, 3 approach. Look at their airway. Look at the quality of the respirations. Begin to assess the circulation, including neck veins, in the primary survey. JVD in the primary survey. Look at their perfusion. How is the radial pulse, the carotid pulse, femorals? Are they weak? Are they strong? Are they thread-like? Thready means thread-like, which means narrow. Or are they absent? Remember, here we go. What would the blood pressure be if you can't feel a radial, but you can be a carotid? You can feel a carotid. What is the blood pressure? Between 60 and 80. Is the heart rate too fast or too slow? Is the rate regular? Is the heart rate regular or is it irregular? My residents here know Fowler's first law. Always explain a tachycardia. Folks, you don't want to be an idiot. You want to be a great clinician. The three great risks of EMS are unsafe driving, advanced airway management, and the non-transported patient. If you have a patient with a pulse of 110 and you're thinking about no loading them, think twice. There's something wrong with that patient. Oh, well, they're just anxious. Have them sit down. If they are just anxious and they sit down, their pulse will slow down. They have a persistent tachycardia, ladies and gentlemen. There's something wrong with that patient. Well, they hit their albuterol inhaler. Okay, well, fine. Maybe you've explained it. But you must explain the tachycardia. Getting a good history, including an account of the present illness and a comprehensive past medical history, is essential to determining the type of shock. We won't spend much time on this. This is in our chapter. Dr. Lippmann and I wrote the new chapter for AMLS on shock. It's called a sampler history. We've added the R to sample, signs and symptoms, allergies, medications, past history, last oral intake, events, and risks. Indeed, your electronic medical record should be modified or adapted to be able to control the sampler mnemonic. And then there's the OPQRST mnemonic for pain. When did it start? The provocation, what makes it better or worse? The quality, the radiation, where does it go? The severity of it on a scale of 1 to 10, and how long has this been going on? I like to add to the time, have they had it before? Yeah, please, Melanie, go ahead.
I don't want to stop you, but just to interrupt, I think that just thinking about what you're talking about and like causes of shock and whether it's medications or other, maybe an allergen they are exposed to, many times these people arrive in the emergency department, they're obviously very sick, they're hypotensive, they're tachycardic, they're altered, as you said. The patient really can't provide much of anything in regard to a history. Now in the days of COVID, relatives aren't even allowed in the emergency department. So I think the ER really relies on the medics and any sort of collateral history that can be gathered in the field, whether it was something they were exposed to, a med, an allergen, there was blood on the scene, etc. Like, I think that is very useful information that otherwise we would never be able to have access to.
Absolutely, that's wonderful. Thanks, that's excellent.
Being really observant, bringing in pill bottles, noting any exposures, or kind of like really being observant when you arrive to try to, kind of put the whole picture together, especially kind of given an altered patient or maybe an elderly patient, their history is going to be very limited. And like we said, especially now with COVID, we can't even get the family in the ER. So we really rely on the paramedics for that.
Absolutely. So let's move on about the medications that affect shock. Steroids can mask the sign of infection, though we may use them later for the treatment of sepsis, possibly. Beta blockers can blunt the compensatory tachycardia. Anticoagulants increase bleeding. Calcium channel blockers inhibit vasoconstriction. Hypoglycemic agents may impair blood glucose regulation. And herbal preparations may exacerbate bleeding. And diuretics can give long-term diuretic therapy, may cause hypokalemia or low blood volume. So what do you want to do? Examine the patient. Get the vital signs. Ladies and gentlemen, this is why they're called the vital signs. These are the critical signs indicating the level of consciousness, the function of the brain, air hunger through respiratory examination, and the status of the vascular system, including the patient's temperature. And these are essential. The most signs of shock are hypotension, tachycardia, tachypnea, and cool skin. Your physical exam then focuses on determining the cause of the shock and selecting proper intervention. Now, moving on, you're going to have diagnostic tools that are used to evaluate patients with signs of shock, such as pulse oximetry, cardiac monitor, 12-lead ECG, we'll come back to that, glucose monitoring, compensatory reserve index, we'll come back to that. That's sort of an advanced shock index, and laboratory testing. Now let's talk about cardiogenic shock for a moment. Look at this ECG, and in your mind for the next 15 seconds, think about what's wrong. Well, let's see. It is wide, it is fast, it is perfectly clock regular. I don't see a P wave. You can argue in V1. Is that a P wave before this wide QRS? I'm not so sure, but I'll tell you this is a 64-year-old patient, and this pulse rate is something around 180. If you use the mnemonic 220 minus age, that will give you the maximum sinus tachycardia that a patient can have. This is a pulse rate of 180 in a 60-year-old patient. This pulse rate is too fast. You may generally state that a wide complex tachycardia is typically about 80% of the time ventricular tachycardia. This is VTAC. You might argue that VTAC and VFib are the 12 leads you never want to get because you should have already treated the darn patient. And in this case, this is an ECG done with ventricular tachycardia in a patient with a pressure of 70. In the field, ETA is 20 to the hospital, pressure of 70, patient altered in VTAC. What is the treatment? I hope you all said synchronized cardioversion on this patient. Thank you, Melanie. Now let's look at this one. Melanie, what do you see on this ECG?
Well, I think it's not too subtle. This is clearly a STEMI. So if you look at the ST elevations, they really extend from V2 out to V5, and then laterally you see them as well in 1 in AVL. So I would call this a big anterior lateral ST elevation MI. And you can kind of further see some reciprocal depressions in 3 in AVF. So it's a big study.
Why would I show a slide like this in a talk about shock? What's that got to do with the price of bread?
Well, if you imagine the extent of the myocardium that is being compromised right now, this is like a large territory of heart muscle that is not getting blood flow to it. So I would be concerned this patient might be hypotensive. And we talked a little bit about cardiogenic shock. I mean, imagine that much of your myocardium is not squeezing properly. You can easily be in cardiogenic shock with an EKG that looks like this.
So wait a minute. I thought they were in the STEMI mode and get the patient to the PCI lab. You're telling me that they come up on a patient and they're evaluating them and they get the 12 lead and they're getting ready for their 20-minute ride to the hospital to a cath lab. They have to worry that this patient may become hypotensive?
Yes, yes.
Because
exactly.
The heart muscle loses horsepower. And what could they possibly have on the ambulance that could help treat this patient? Let's take a look at that. So as part of the routine evaluation, don't forget to do glucose monitoring. Significant hypo or hyperglycemia should be considered in the differential diagnosis. People with severe hyperglycemia pee out a lot of glucose, which takes volume with them, and they can be hypovolemic. Patients with severe hypoglycemia may have altered mental status and have to be treated. Now, Melanie, you talked about shock index. Would you go over that again? What was that number again?
Yeah, so like the shock index, like we said, I love it because it's so easy. It really doesn't need math. I mean, technically, if you were to calculate it, it's the heart rate over the systolic blood pressure. So like we said, in a normal person, that's maybe a heart rate of 60 over a systolic blood pressure of 120. That's a ratio of 0.5. 0.5 to 0.7 is normal. Anything above 0.7 is technically elevated and indicative of shock, but you don't really need to get that worried until it's 1 or greater. And that's why I say you don't even need the math, because once the heart rate is greater than the systolic blood pressure, that's a marker of significant shock.
But now, wait a minute. What if you saw blood on the scene and their pressure and their pulse was initially 60, and then it goes to 80, and then it goes to 90? It's increasing. Shouldn't they be worried about that?
Yeah, I'd be worried. I mean, if you have an elevated shock index in the setting of hemorrhage, that's, you're in hemorrhagic shock. The elevated shock index is like highly predictive of that patient requiring blood. So the faster they get to whether it's in the back of an ambulance or in an emergency department, it's very likely they're going to need to receive blood, and the faster that can happen, the better for that patient's mortality. Say, for example, if you see an elevated shock index in the setting of sepsis, that person straight off needs fluids. It's also predictive they might need vasopressors, and of course they need source control.
Yeah, now it turns out, folks, that with the advance of science, everybody has a smartphone on their bottom now, in their back pocket, that increasing ability to try to look inside the patient to find out just how much cells are starving for oxygen is gradually coming available. And with the passing of the next few years, you may see a thing called the compensatory reserve index, that if you'll follow the cursor, is just basically able to predict the fact when the cells are actually starving and the vascular system is failing, to actually predicting the point where the patient will decompensate and the patient may in fact die. And there are devices becoming available. You see one here that actually you could wear on the wrist that, using pulse oximetry and pulse rate, could actually do a calculation of such thing as a compensatory reserve index. We may see this becoming a technology in the future. Yes, Melanie?
Through the finger, I mean, it's kind of impressive, the technology, like just through that finger monitor, it's doing a continuous monitoring of the arterial pressure. So we can get beat to beat changing measurements that kind of can see shock happen over time. It is a proprietary device. So, and it's not, like you said, readily available, but maybe something to keep an eye out for in the future.
Well, I came out this will be crazy to the folks on the phone here, but I came out a long time before pulse ox, and then we had pulse ox, and then years later we had capnography, and then years later we had 12 leads. I know that seems like an old guy talking, and I am an old guy talking, but the good news is that with advancing technology, we're going to have more and more ways in which we will be able to see into patients. Now we're going to take them to the hospital. Now you can do a glucose. You might even be able to do a hemoglobin in the field. Point of care hemoglobins can be somewhat notoriously unreliable in patients with different vascular volumes. We might check their gastrointestinal tract to see if they have blood in their stool. We will be drawing a lactic acid to see if cells are starving for oxygen. They quit producing pyruvate and start producing lactate, and that is a sign of shock. We'll do blood counts. We will look at acid-base balance, actually measuring blood pH, blood bicarbonate levels, looking for the partial pressure of carbon dioxide, which we do with waveform capnography through the pulmonary tract, and we'll be looking for blood oxygen as well. We will also be drawing serum electrolytes. We will be looking at renal function through such things as creatinine and the blood urea nitrogen. We might do blood and urine cultures if we thought the patient might be septic, and then we might do a compensatory reserve. I would encourage you also to think about the shock index that Melanie has been talking about. So you may have determined in your primary survey that the patient was in shock, but you may not have yet determined the underlying cause. It is important to move briskly, move quickly through this assessment with the calculated purpose of doing a thorough exam and not leaving out steps. Stop bleeding, assist ventilation where need be, give the patient a pulse if they need one. Otherwise, be thorough in your primary survey and in your secondary survey. Ladies and gentlemen, if you do not look at neck veins, you will not see neck veins. And you're saying, oh, that stupid guy. I am telling you that plenty of residents who come and present cases to me have not looked at the patient's neck veins. And it's a patient in congestive heart failure, for God's sake. So you must get into the habit of having a very thorough, regimented physical exam that you do not leave out steps. I know that no one on this call leaves out steps, but you must be in the habit and in the practice of not leaving out steps. You must assess, intervene, and then look again. Ladies and gentlemen, patients change. You put pressure on bleeding, the pressure comes off, they start bleeding again. Their pulse was 60, but they're bleeding internally, and now it's 90, or now it's 110, and their shock index has gone from 0.5 to 1.2. So during your ongoing management, repeat the primary survey. In the old BTLS days, we called it the third survey. The first, the second, and the third survey. The third survey was the repeat primary and the vital signs. Revisit the chief complaint. How are you feeling? How is your pain? Monitor the patient's response to any treatment, and always consider the possibility of trauma. Now, if you think the patient is in shock, especially if they're hypovolemic, you might want to give an initial bolus of 20 or 30 cc's per kilogram. Basically, it's about a liter or two of an isotonic fluid like saline, like lactated ring, to give if the patient shows no signs of fluid overload. What are signs of fluid overload? Jugular venous distension, especially if the patient's sitting up at about 30 degrees or more. If the patient's at risk for fluid overload, then a more modest bolus of 250 to 500 cc's followed by a reassessment is appropriate, such as what? The patient's in cardiogenic shock due to a heart attack, but they are hypotensive. The blood pressure is the more dangerous problem. The purpose, folks, of the fluid should be to enhance perfusion, getting blood supply to the rest of the body, to maintain a mean arterial pressure of 60 to 70, or make it easier, a systolic pressure of 80 to 90. What does that mean? Get a radial pulse back. Say, oh, right, 80, right. Get a radial pulse back. If bleeding is suspected, stop the bleeding, and administration of blood products can be indicated. In San Antonio EMS system, one of the true great EMS systems anywhere, they have whole blood in the field for symptomatic hemorrhage, such as including postpartum hemorrhage and, of course, trauma. If massive transfusions are required, early administration of fresh frozen plasma and platelets has been shown to improve survival. Keep the patient warm. The body expends a great deal of energy keeping the patient warm. Keep the ambulance warm, keep the resuscitation bay warm, and administration of warm fluids will assist in helping maintain temperature. Vasopressors are medications which help constrict the arterioles, augmenting blood pressure, and they can be an efficient adjunct treatment in patients with certain types of shock. Vasopressors include norepinephrine, which is the preferred agent in most shock scenarios requiring vasopressors. Epinephrine can be used, preferably a drip. Phenylephrine can be used, and dopamine is less preferred. Yes, Melanie?
I was going to ask you, as you said, norepinephrine is the preferred vasopressor in almost any type of shock. Can you name one where that would not be the case?
Well, I have to think about it for a minute. You tell me.
How about anaphylaxis?
Well, why not? I mean, it's a vasopressor, right?
Yeah, epi, the main reason people die from anaphylactic shock is the lack of epinephrine. So if you ever see somebody in anaphylaxis, particularly in anaphylactic shock, I would say have a low threshold to give them epinephrine if you're at all concerned.
Then inotropes that we can use to make the heart beat stronger include dobutamine. Norepinephrine can work. Epinephrine also works. Dopamine now is being less preferred. We may have to give blood, and it may be a viable option in the pre-hospital setting, especially in air ambulance or interfacility transfer. If the patient is actively bleeding, is anemic, or is in a serious shock or a serious bleeding disorder, administration of blood and platelets is indicated, and I will refer you to this slide for your reference when the slide is downloaded. The problem, there is no free lunch on these transfusions. There are generally two complications: infection from blood and immune reactions to blood. Fortunately, screening donors and blood products can improve the risk of spreading infection, and there is a small risk, especially for cytomegalovirus, which is a common virus in the population. About hemolytic reactions, when the recipient's antibodies recognize and react to transfused blood as an antigen, the donor red cells may be actually broken down by the recipient's bloodstream. That is called a hemolytic reaction. Most transfused cells are destroyed in an overwhelming immune response. Now, inadequate circulating fluid leads to a diminished cardiac output, which results in inadequate delivery of the cells. What do? Look at the box. Stop the bleeding and consider blood product transfusion where appropriate. Now, distributive shock, it stems from a precipitous increase in the vascular capacity because the blood vessels dilate and capillaries leak. This leads into too little peripheral resistance and a decrease in preload, which in turn reduces cardiac output. Those causes include sepsis, anaphylaxis, neurogenic shock, and toxins. What do? You give fluids. you give antibiotics, you give vasopressors for sepsis, for anaphylaxis. As Melanie said, give epinephrine. Epinephrine is life-saving in anaphylaxis. Neurogenic shock, you may have to give an IV bolus, consider norepi, and in toxins, you will base the treatment based upon the specific agent. In cardiogenic shock, the errors occur where the heart is unable to circulate sufficient blood to meet the body's needs. It could be right-sided or left-sided ventricular failure, including arrhythmia, cardiac structural disorders such as MI, or the action of certain toxins. To treat them, what do? We must focus on stabilizing the airway, get oxygen into the patient, and manage the circulation. Look at the yellow box. We give them oxygen. We give them an IV fluid bolus. Remember, if there's distended neck veins, we may have to give a little less. We correct the rate, such as cardioverting ventricular tachycardia, give inotropes, vasopressors. And at the hospital, we may have to intervene with an intra-aortic balloon pump. Obstructive shock occurs when there is an obstruction to blood flow, typically in the chest. This causes include tamponade, pulmonary embolism, and tension pneumo. The initial management should include focusing on increased vascular volume, get some fluid in the patient, and then try to correct the problem when you find it, such as needle decompress the tension pneumothorax. Beware of the cyanotic shock patient with JVD who has unequal breath sounds. Unequal breath sounds are very hard to hear in the field, but we would decompress the tension pneumo. A pericardiocentesis can be done for a pericardial tamponade and obviously transport the patient to the appropriate facility. Early identification of the patient's stage and type of shock is essential in putting this all together so that you can manage the condition. Sound reasoning, a thorough assessment, and careful but expedient interpretation of diagnostic findings are necessary to provide effective treatment for shock for the patient who's in shock. Ladies and gentlemen, this is the era of embracing what a paramedic can be. Excellent historian, excellent physical assessment, embracing new technology as it comes out. Melanie, closing comments?
Oh, can I just re-emphasize one thing with this slide? You know, sometimes like we talked about before, a patient comes in, they're altered, they can't really give you much of a history in any sense, and they're clearly in shock. This is like extra important, I think, if there's any identifiable clues on the scene, like blood loss, pill bottles, allergens, like we said before, we might never have access to that medication list, or certainly if there were needles on the scene or anything that really kind of could identify the reason why they're in shock, whether it was a toxin, it can be super important.
All right, so Melanie, you got a 70-year-old guy with a history of cardiac disease who's been stung on the butt by a bee. His pressure is 70, his pulse rate is 130. He has hives, he is gray, he is altered, but he has a cardiac history. Can you give him epinephrine?
Absolutely, and in that setting, there's really no contraindication to epinephrine. So he absolutely needs epinephrine, 0.3 to 0.5 milligrams IM to start, and may need repeat dosing.
But Melanie, you might give him a heart attack.
If you don't, he's gonna die.
So you're saying there's sometimes that we get into a risk-benefit ratio.
Yeah, every single medication, every single intervention has a risk and a benefit. So I think that is the idea between that's kind of like what goes behind all medicine, right? To give blood, to give fluids, to give certain medications, everything is weighing the risk versus the benefit. In this case, 100%, I would be, that it falls in the favor of the benefit you will receive from epinephrine. I will certainly take that over the small risk of stressing his poor heart's function.
Moreover, his shock could stress his heart function as well. So, Melanie, a different question. What happened to dopamine? We used to give dopamine like water. What happened to it? How come it's de-emphasized today?
Well, it's tricky. It's kind of dose dependent. It's very pro-arrhythmogenic. And I think it's kind of an old medicine. Like, again, your friend Amal Machu, the EKG expert of emergency medicine, likes to call it, I think, a dinosaur looking for a tar pit. There's just so many better alternatives that dopamine is really kind of like one of those older medications that is kind of fallen out of favor now that we have better options. And its primary reason that we don't like it is because, like we said, it's very, it has a great propensity to cause tachydysrhythmias. And unless you had a profoundly bradycardic patient, perhaps you might choose dopamine, but really there's so many better alternatives. And for almost any type of shock, if you're not sure, norepi is first line. I would say except anaphylactic shock needs epi. Of course, hemorrhagic shock needs blood. Pretty much anything else, if you were to need a vasopressor, norepinephrine would be a smart first line.
One thing that's not widely known about dopamine is that dopamine actually has to be metabolized to have its effect. And so dopamine is metabolized to norepinephrine in the sympathetic nerve cells. And so your patient in shock has to have enough perfusion around that the sympathetic cells themselves can change dopamine into norepinephrine, where it then has its vasopressor effect. Well, let me now, Melanie, let me now call on Nancy Hoffman to, or whoever's back there, to present some questions for the next 5 or 6 minutes from the folks on the call. Who's out there to give us some questions?
Yes, thank you, Dr. Fowler and Dr. Lippmann, for sharing this vital information with us today. Throughout this webinar, we've been collecting participant questions. We'd like to take this opportunity to pose some of those questions to you. As a reminder to the audience, we may not be able to address all of your questions today, but we will provide replies to unanswered questions on our website, along with a recording of this webinar. So the first question for you both is, in the presence of hemorrhagic shock, what are alternatives to blood transfusion? Our hospital is a patient blood management center that would like to consider alternatives to transfusions.
Well, I'll start, Melanie, you can follow up. Nearly 50 years ago, when I started medical school back in the early 1970s, we were still having the debate of whether lactated ringers was better than normal saline or vice versa, and that's a whole discussion. Here's what we really didn't understand then. What is in whole blood is not in fluids like lactated ringers. You have oxygen carrying capacity, you have platelets, and you have protein clotting factors. You have to have whole blood inside your vascular system. This is why San Antonio Fire Department has moved, the EMS system, has moved to having whole blood in the field, because nothing replaces whole blood volume. Melanie?
Yeah, I mean, it's tricky, but I think the other piece of it is really stopping the bleed. So I mean, you can, if there's a bleeding vessel that you can get control of, maybe like tourniquets. Tourniquets can be life-saving. Identifying a source that you can stop in the field is another way that you can deal with or prevent hemorrhagic shock from getting worse if you don't have immediate access to blood. But ultimately, these people are losing blood. They need blood back, so they need to get someplace where they can get blood back.
One other point is that if you have a patient who's had massive blunt trauma and they've got a distended abdomen post-trauma, they're in shock, deep shock, be cautious about normalizing their blood pressure. Don't give them a blood pressure back to 120. Get them a radial pulse back, which is what is called a peripheral pulse. Because you can, if you have someone with a bleeding aorta or a bleeding large iliac vessel, for example, you can raise blood pressure and make bleeding worse. So in the setting of someone in deep shock that you suspect is hemorrhagic and that the bleeding may not be controlled, internal, for example, do not normalize their blood pressure. Next question.
Next question is, how would a patient with adrenal insufficiency impact shock and shock management?
Melanie, you take that.
Well, that's a good point. So these people that are adrenally insufficient might need steroids. Sometimes we take care of people that have adrenal insufficiency and they're not responding to fluids and they're not even responding to vasopressors. They might need some steroid. So if you have hydrocortisone, or I would take that. Any steroid you have is going to be necessary for them to respond to the other interventions that you're doing to reverse their shock.
Yeah, but who are people who might be steroid dependent and we don't even realize the fact that they may get into adrenal insufficiency and shock. I'm thinking somebody who's had asthma and been on steroids for years, and then they suddenly get pushed into sepsis, and they go into an Addisonian crisis, an adrenal insufficiency crisis.
Yeah, I mean, if they're not responding to the typical interventions like fluids and vasopressors, you might just empirically give them steroids in the event that they could be adrenally insufficient.
Great. Next question.
Okay, I think we have time for one last question. Will one of you two please comment about pulse ox values at altitude? A pulse ox of 92% has significantly different meanings for a person at sea level versus a flatlander who has only been at altitude for a short while.
That is absolutely an excellent point. And if one has never climbed mountains before, one has not experienced the dubious pleasure of watching pulse oximetry go down because the relative pressure because the overall pressure of oxygen goes down because the overall atmospheric pressure goes down as well. And so thus it's absolutely quite true that if you are on a mountain, we had a speaker last night who climbed Mount McKinley at Dr. Gardner at 19,000 feet. And up there you have a pulse ox of 72. And so it can be absolutely true that you have to take the patient into perspective. Melanie, any last comments?
Yeah, I mean, like you said, they might have a pulse ox in the 70s when they're at a significant altitude. Like, I think you can look for other markers like their mental status. Are they altered? Are they confused? There's other markers that can make you more or less concerned when the number is so dependent on altitude, I think.
All right, well, there you are.
Thank you again, Dr. Fowler and Dr. Lippmann, and thank you, Ninth Brain, for sponsoring today's webinar. And thank you all for attending today's webinar.